shoulder pain that's not coming from the shoulder. This case was prompted by a recent experience we had in clinic of a lady who had been diagnosed and treated for a persistent rotator cuff problem for about 6 months. And rotator cuff pain in the shoulder is a very common scenario, just like lower back pain. Really, it tends to be used as a very general description of symptoms, but there are pretty clear-cut signs when you examine a shoulder in terms of whether the tendons themselves are actually causing symptoms. And one of the surprising things for me was that this lady had a good range of motion. So when she tried to move her arm through space, there was a reasonable range, which usually means that there isn't a tendon getting pinched or caught. Now, sometimes you'll see less severe tendonitis where range of movement is good, so there isn't a restriction in flexibility, but when there's a bit of pressure put on the arm, so when you load it or people do a functional task that puts pressure through the arm at certain angles, then they'll get a pinch or a catch because the tendon is getting caught under the bony structure on the top of the shoulder typically, or can be caught in other parts of the shoulder too. But that's the general principle. That's why the technical name for this is called an impingement, as in a pinching scenario. But anyway, we weren't able to reproduce symptoms in this particular case, which made me wonder really, well, are the symptoms coming from the shoulder? And the alert clinician in that situation needs to explore other regions that may potentially be contributing to symptoms. So when we explored other areas, and those areas typically would be the neck, the C5, 6, 7 vertebrae in the neck, because they share the same nerve referral pattern into the shoulder. So if there's sensitivity in the neck, and often people won't be aware of those joints being sore, but sometimes you can reproduce the symptoms by stressing those areas. So that tells us it's a factor. But in this particular case, the tissues of most sensitivity were the first and second ribs. And people are surprised to hear that, but the collarbone is located in this area here, and right in behind it is your first rib, which is a little small cylindrical circular structure that just it sits in underneath there. And then the second rib is a little bit bigger than that, and they're located at the back of the spine as well. So they come around into what's described as a bucket handle. So we're all pretty clear of visualizing the ribs lower down in the torso, but as the torso rises up into an apex, those ribs gets much smaller. But nonetheless, the ribs were particularly sore and stiff and sensitive when we examined them, and reproduced shoulder pain. So it's one of those things that can mimic a shoulder problem, because when you move the shoulder, you do also move the ribs in that area. You move your upper back, you move your neck, or the muscles that produce the movement in your shoulder tense and put pressure on those other structures. So it can sometimes mimic a problem in the shoulder because it's associated with movement. But then when you go and explore, you're looking at specific provoking tests to try and confirm the diagnosis. If things don't match up, it always should alert the clinician to start looking in other directions. And this was one of those cases where there was an absence of signs in the area compatible with the diagnosis. And when we looked in other areas, there were things that were more compatible. Now, sometimes if you've had a shoulder issue that's gone on for many months, it does change how you move. So typically, if you haven't got the freedom to move in the ball and socket, or if it's sore to do so, people tend to use a different strategy to move, which can involve sort of shrugging the shoulder up. And in that situation, you'll often find tension and tightness in the muscles, in the neck and upper back, and also in those joints as well. So sometimes it's a bit of a chicken and egg type debate as to which came first, what's a primary problem and what's a secondary problem. And often in clinic, you've got to commit work into both areas to try to speed things up at the same time, because the region functions as an integrated unit. So it's only as good as the weakest link in the chain, so to speak. So that was an interesting case, but we see that sort of pattern very commonly, and it's very common to see people with shoulder issues where there's a coexisting cause in the neck or thoracic spine or upper back. So you generally don't get a good result in terms of outcome unless you identify all the areas that are causing pain and have a treatment plan directed towards that, and that treatment plan needs to involve some manual therapy, some specific stretching, some self-mobilizing, as well as some strengthening and movement type of rehabilitation regime. So you need to encompass all of those things if you're looking to get a lasting solution, really. So an interesting case. Thought it was worth sharing with you, particularly if you're in a category of persistent shoulder pain that's not responding. And the question then really is, well, is this a problem where there are just too much change in the shoulder joint, and that really would be somebody, with more advanced changes with a very clear history. If it's not a clear history of trauma or degenerative change, then you're not really likely to be in that category. So it's a case of, are there other things causing the problem? And if it's not responding to treating as a local shoulder problem with typical rotator cuff rehab programs, then it's making you think that maybe there are other factors contributing to this that need to be identified. So it's a common one we see clinically, and one that you just need to be aware of. Hope you found that interesting. I'll see you again on another video. Bye for now.